Have a very good agenda today. Before we start in the roll call, please allow me to recognize our newest member of our committee, Senator Chambers Armstrong, and certainly glad to have you as part of our team here. So if you would, please, everybody welcome Senator. Any other guests that we need to recognize this morning? If not, we'll jump right into the agenda. Secretary, if you would, call the roll.
Senator Rocky Adams. Senator Chambers Armstrong. Senator Berg. Senator Carroll. Senator Funke Fromeyer. Present. Senator Nemes. Present. Senator Tishner. Present. Senator Wise. Here. Vice Chair Douglas.
Present.
Chairman Meredith.
Present. We do have a quorum and we will proceed. First bill on our agenda this morning is House Bill 75, and Representative Brandon Reed is here along with some guests. If you would, Representative, you as well as anyone knows the routine. We are reviewing House Bill 75 this morning, and I think it's a matter of coincidence, maybe not, that back in 22, Representative Reed also did House Bill 183, which is quite similar in scope to this bill. But if you would, Representative, please identify yourself for the record and proceed.
Thank you, Mr. Chairman. Thank you, honorable members of the Health Committee on the Senate. Truly appreciate the opportunity to come before you today. I am Representative Brandon Reed. I represent the 24th House District, that's Green, Hart, and LaRue counties. I do have a distinguished guest with me today. I will allow her at this time to introduce herself for the record.
Good morning, Nancy Galvani, President of Kentucky Hospital Association.
Mr. Chairman, members of the committee, HB 75 is aimed at improving access to the quality health care for each and every Kentuckian, as well as serving as a lifeline to rural hospitals serving communities throughout our Commonwealth. With HB 75 now granting access to hospitals to be reimbursed for outpatient services, hospitals will be able to harness federal resources while using no state funds. This measure simply builds on legislation, like the chairman referred to earlier, we approved back in 2019 and 2021 with House Bill 183, and provides an additional opportunity to harness federal resources. There is a budget mechanism for pass-through money that will be coming over in House Bill 448 through the budget process, but at this time, my guest has a few words to say, if that's okay with you, Mr. Chairman.
Thank you so much. Again, Chairman Meredith, for allowing me just to make a couple brief comments about the need for this bill. It's very critical to support our hospitals, because our hospitals, as I've testified in front of your committee in the past, are really facing skyrocketing expenses, and the revenues just are not there to cover that. And I wanted just to let everyone know that today a new report is coming out by Kaufman Hall. And Kaufman Hall is a national management consulting firm. They do national reports on the state of hospital finances. And so we contacted them and asked them if they would do a report just for our state. And so that is what is being released today. And I just wanted to let everyone know that report is echoing what we have been saying all along. And basically, the report found that in 2022, Kentucky hospitals faced their most challenging year financially since the start of the pandemic. They found that inflation, record high operating costs, and lower patient volumes led to unprecedented financial losses. They found that 38% of the state's hospitals are at risk of closure. A couple of the other highlights: operating expenses for our hospitals increased $4.2 billion since 2019. Labor expenses increased approximately $3 billion. The hospital spent $1.2 billion more in contract labor in 2022 than they did in 2019 prior to the pandemic. The growth rate in contract labor, medical expense, and drug expenses were higher in Kentucky than the national average. And in fact, the medical and the drug cost growth grew at more than 2 times the national rate. And so, as everyone knows, 3/4 of our patients in hospitals are on fixed payment from Medicare and Medicaid. We can't pass those costs along. And so the result is that Kentucky hospitals ended 2022 with a negative operating margin, equaling a loss of more than $250 million. And what's really important is that those losses occurred despite having the inpatient HRIP program. And so had we not had the inpatient HRIP program in 2022, the losses would have been much greater. In fact, according to this study, they would have exceeded $1.3 billion. So this bill is very critical. We want to thank the members of the General Assembly for your support of this measure, and just can't echo enough that the timing is very critical for this, and we really need it to sustain our hospitals. Thank you.
Thank you, Mr. Chairman. I'd like to thank the Kentucky Hospital Association, the many co-sponsors, and the bipartisan work on this bill. That concludes our presentation.
Representative Reed, I always appreciate your commitment to this as well. Know your district well. I appreciate your commitment to it. Nancy, you threw out a statistic of 38%. Could you give me that number again?
Yes, this study found that 38% of our Kentucky hospitals are at risk of closure. And that's an increase. That's an increase.
Can you kind of stratify that a little bit between urban and rural?
They did not do that. They did not pull that apart. But I will say the sample of hospitals they looked at had both urban and rural in there. So they said it was a very statistically valid analysis.
Well, I remember even before COVID, I think the average profit margin for particularly rural hospitals was less than 0.5 of 1%. And if it hadn't been for HB 183, I'm sure that number would have been even greater. But I think from a lot of the facilities that was going to be the saving grace for them.
Yes.
And I heard from a lot of hospitals that they were thrilled to have that additional reimbursement. But I guess that exuberance is short-lived when you're faced with the kind of inflationary pressures we're dealing with right now.
Yes.
So even with the passage of this bill, which I think is critical for all healthcare providers, what do you see coming next?
What this report shows is that there's no relief in sight for these high costs that are out there. So again, that's why this bill is critical, and particularly for our rural hospitals, because the majority of the money that's going to come in under the outpatient side of HRIP is going to go to the rural hospitals, and they desperately need it.
All right, thank you. Motion on the bill, is there a second? Second by Senator Nemes. Secretary, please call the roll.
Senator Rocky Adams. Senator Chambers Armstrong. Senator Berg.
Aye.
Senator Carroll.
Aye.
Senator Douglas.
Aye.
Senator Funky Fromeyer. Senator Nemes.
Aye.
Senator Tishner. Senator Wise.
Aye.
Chairman Meredith.
Aye. Bill passes with unanimous consent. We'll proceed to the floor with favorable expression. And, you know, I would ask for consent on this one, but folks, I really would like to be able to speak about this on the Senate floor, because I think we need to make people aware that how critical this situation is. And I envision that when we come back in 2024, we'll need to try to examine other measures that could address this situation. But appreciate you being here this morning. And
thank you, Mr. Chairman.
Bill.
Thank you all. Appreciate it.
Thank you. Next bill is House Bill 180, and that's the Representative Moser is present along with guests. For those of you who are not new to this committee, we heard this topic during the interim. Great presentations on a lot of different folks' part. It's a very interesting subject matter. With that, Representative Moser, I'll defer to you. If you would identify yourself for the record, feel free to proceed.
Absolutely. Thank you, Mr. Chairman. And I am Representative Kim Mosier. I represent the 64th District, and I'll allow my guests to introduce themselves for the record.
Hi, I'm Leah Phillips, and I am from Oldham County, Kentucky.
I'm Dr. Michael Gieske. I'm with St. Elizabeth Healthcare in Northern Kentucky. I'm the Director of Lung Cancer Screening.
And then online we have Dr. Jill Colasar from the University of Kentucky. I don't know if she's on.
Can you hear me and see me?
Yes, thank you.
Oh, thank you.
If you could just introduce yourself for the record.
Hi, I am Jill Colasar. I'm a professor at the University of Kentucky, and I work I'm also the Director of Precision Medicine Initiatives at Markey Cancer Center.
Wonderful. All right, thank you. I appreciate the opportunity to be before you today, and thanks to the committee for hearing this bill. This House Bill 180 is about getting the right treatment to the right patient at the right time. It saves precious time, it saves healthcare costs, and it saves lives. So the problem is that most of us have been touched by cancer. We all have loved ones, or we know someone who has had devastating side effects of their chemotherapy, perhaps a treatment that didn't work right away, and they've gone through cycle after cycle of trial and error. And what House Bill 180 does, it simply requires health benefit plans to cover biomarker testing, which is ordered by their physician and will provide the correct diagnosis. Well, a healthcare provider who has treated a patient and diagnosed their cancer, what this does is targets their biomarker, identifies the patient's biomarker, and will identify precision treatment for their cancer. There's currently limited and disparate access to this biomarker testing because of a lack of insurance coverage for everyone, but especially in the minority and poor and rural populations. The fiscal impact study returned saying that this is not expected to materially increase premiums or the cost of health care in the Commonwealth. Oftentimes we know that, as I said, patients are getting what has been thought of as historically appropriate treatment, but it isn't. And again, this just gets precision treatment to the patient. It improves outcomes. I think at this point, I will just hand it over to my guest. Maybe Dr. Kolesar, if you can tell us a little bit about the background of biomarker testing and exactly what it does. I think it's a great education for all of us.
Thank you very much. I have some brief remarks and a few slides. I'd like to start out by letting you know about the difference between somatic and inherited. Somatic is something that is only in the cancer, where inherited is going to be passed down from children, down to your children. Approximately 90% of cancers are caused by somatic mutations, and another 10% are caused by these inherited mutations. And it's very critically important that we are able to understand what these mutations are, because it helps us select the correct treatment for patients, as well as prevents adverse effects. I'd like to next show you how far we've come since we've known about biomarkers. For those of you who are not used to looking at these survival curves every day, 100 means 100% of the patients are still alive, and 40 means the time. And so looking at the left panel, in 2002, the median survival for patients diagnosed with non-small cell lung cancer was 8 months. And it didn't matter what treatment you used, they all turned out to be about the same. Now, jumping ahead 20 years to 2022 and looking at the panel on the right, we have made tremendous strides in improving outcomes for our patients with lung cancer. The survival now is 4 years, again, compared to 8 months just 20 years ago. And the major reason for this improvement is in lung cancer, there are at least 12 different gene targets or biomarkers with more than 25 possible drugs. And I'd like to emphasize that more than 75% of patients with non-small cell lung cancer are going to be eligible for one of these treatments based on their biomarker testing. Let's take a little dive into what we are seeing more commonly in Kentucky. What this slide is showing you is that the rate of testing is low. There are a variety of reasons for that, including the lack of insurance coverage. And patients who are unable to access this treatment have poorer survival. The other thing that we know is that if you are living in Appalachia or you have Medicare or Medicaid insurance, you are also less likely to receive this testing. One of the initiatives of the Markey Cancer Center was to develop a molecular tumor board that it was really an implementation strategy for precision oncology, which is available free of charge to all medical oncologists across the state of Kentucky. And the idea behind this molecular tumor board was really to improve knowledge and understanding and uptake of this testing. I'd like to share with you just one of our outcomes. And again, these are going to be survival curves. And the red curve are patients who had a molecular tumor board review compared to the blue curve where patients did not have a molecular tumor board review. And what I'm showing you here in panel A is patients in Kentucky over the last few years who had biomarker testing and received a molecular tumor board review survived 8 times longer than their matched counterparts. It did not matter if you were taken care of in the community or an academic setting. And it did not matter whether you were living in Appalachia or an urban area. As long as you received this care, you did have improved survival. Thank you very much. I'm happy to take questions.
Thank you so much. I think we'll hand it over to Leah for a moment.
Hello, thank you for having me today. Like I said before, I'm from Oldham County. I actually grew up in Jefferson County and lived in Kentucky my entire life. In December of 2019, at 43 years old, I was diagnosed with stage 4 non-small cell lung cancer as a never smoker. At first, my diagnosis, when I was first given that diagnosis, they told me they hoped I was here a year from then. At diagnosis, they wanted to treat me with chemotherapy and immunotherapy, which would have been the standard course of treatment for a typical lung cancer patient. A different oncologist recommended that we do biomarker testing. So my biomarker testing revealed that I have the EGFR exon 19 genetic marker, which qualified me for targeted therapy instead of traditional chemotherapy, which increased my life expectancy, by 5 years. So I have less side effects, less severe hard side effects. I exercise 6 days a week. I have 3 kids. I run them everywhere, and I live a pretty normal, healthy life for someone with stage 4 metastatic cancer. Without biomarker testing, obviously, we heard from Dr. Kolesser, my outcomes would have been much less. I feel this bill is extremely important, not just for people like me that are educated and have access to this testing, but all Kentuckians, no matter their age, their race, or their economic status, because it is life-changing and life-saving for many of us.
Thank you, Leah. And so you can see how important this bill is just to allow the testing to be covered. Dr. Gieske, would you like to add anything?
Sure, I could say a few brief comments based on my experience. I've been in family medicine for 36 years now, and I've seen a lot of patients with cancer and dealt with them and their families, and it's always been a very difficult conversation. That conversation has gotten a lot easier over the last 10 years or so. We've made tremendous progress with all types of cancer, and a lot of that progress has been based on biomarker testing, either through liquid biopsies, which are blood tests, or through tissue biopsies. My background and my experience is specifically more with lung cancer, since I'm the director of lung cancer screening, but as we know, lung cancer is a terrible problem in the state of Kentucky. It's a very deadly cancer. It moves quickly through the stages, and unfortunately, it's often not found until it's late in the course of the disease. We're going after it now through our lung cancer screening program. We're finding it early and making a big difference for the state of Kentucky and for our country. But even when we find cancer in the late stages, stage 3 and stage 4, the message is very different now than it was just 10 to 15 years ago. We have patients now that are living 5, 10, 15, 20 years with stage 3 and stage 4 lung cancer. When I was in practice just 10 to 15 years ago, when we saw a patient that had stage 3 or 4 lung cancer, we felt that it was unlikely that they would be alive a year later. 50% of the people that present with stage 4 lung cancer or with any type of lung cancer do not survive more than a year. With the advent of biomarker testing and targeted therapies through precision medicine and through immunotherapy, we are making a big difference. And the family of lung cancer survivors is growing in numbers. Their voices are getting louder and stronger. And I and many others stand with them and feel that this type of progress should be available for all and not just for some, and that's what this bill is about. Thank you.
Thank you, Dr. Gieske. And I'll just close with, this is a standard of care. It's just not being covered by insurance companies. This is really cutting-edge treatment that Kentucky needs to get on board with. We are #1 in the nation for lung cancer, and we have to change that. So that's what this does, and I would appreciate your support.
Thank you. Fascinating presentation. It was as good today as it was when we heard it this past summer. And Ms. Phillips, I want to congratulate you on your recovery and appreciate you sharing your personal experience with us. But Senator Funky Fromeyer, you have a question, comment?
And thank you. And Leah, thank God those 3 kiddos are blessed. Is this treatment also commensurate with the patient's commitment to their own recovery or their own? When I hear that you're working out 6 days a week, is patient compliance going to also be a factor in whether this biomarker testing is effective for one patient if they're non-compliant versus Leah's commitment to be very committed to your own health and improvement? And I don't know that that's a question for you, Leah. It might be more of a question for our oncologist.
Yeah, I can.
Go ahead.
I mean, I could certainly add to that. Yeah, patient compliance is very important. As we know, cancer has many etiologies and factors in both the diagnosis and the response to treatment. Anyone that exercises, eats well, and takes care of themselves is going to be much more likely to do better with their cancer treatment. If they quit smoking, for example, reduce drinking, reduce weight, all those types of things are going to improve your survivability. But the drugs that we have available now are really the mainstay. I mean, just incredible success that we're having now with precision medicine and targeted therapies.
And I would say too, the targeted therapy that I'm on typically has a effectiveness for 2 to 3 years. I've been on it a little bit over 3 years. It's not a matter of if my cancer will progress, it is when will it progress. I will have to have biomarker testing reperformed to see if I have any new genetic mutations that would qualify me for additional targeted therapies that could be either added to the one that I'm currently on or added with traditional chemo in order to prolong my life even longer. So for those of us that are stage 4, that you're never going to be truly cured, stable is what we hope for, or no evidence of disease, then we need this biomarker testing to be able to receive the next best line of treatment as we go down our journey of this cancer diagnosis.
Mm-hmm. And I guess I would just add that this is really about covering the testing, not mandating any sort of treatment coverage.
Yes, please.
And this is me trying to learn a little better the legislative process as well, that if we were talking just before you about the affordability of costs and such. But sometimes I wonder whether we're spending dollars on a path that a person's not even committed to being on that path, but yet they've been placed on that path because their insurance might cover it, but they haven't necessarily been committed to that path of health or improvement or treatment. So my question comes back to what do we put in place to monitor the effectiveness based on compliance? Therefore, we can make adjustments for not making it available to those that aren't committed to compliance of improvement.
Yeah, and I think I understand your question. You know, when a patient is diagnosed with cancer, I think it's our obligation to offer the best treatment, and part of that is in doing this testing. We can't require that a patient comply with their treatment. Certainly, cancer patients are worn out by the end of some of their treatment. My mom was that way. After 3 years, she said, "I've had enough." So, you know, while we can only offer the treatment, we can't require compliance. And I don't think that we can separate out who will be compliant and who isn't and offer treatment only to people who would be compliant. I think that if a patient is diagnosed with this serious disease and they are going through the steps of getting biomarker testing, they're likely going to be very worried about their situation, and they are going to do everything they can to be compliant. So, you know, I know that there are reasons why we think that patients aren't being compliant. Maybe they're, you know, having a hard time quitting smoking. In Leah's case, she was a never smoker. You know, maybe individuals are individuals. So I think our job is to just ensure that folks have the option for this treatment.
And being on targeted therapies do give you less harsh side effects. So I physically feel good. Whereas I've met other patients who are on traditional chemo and they are so sick they couldn't work out if they wanted to. Whereas since I've been given this gift of feeling semi-normal, then I can take advantage of that to help myself as best I can. Whereas someone who's on traditional therapies may not have that luxury because they physically, their bodies just can't do it.
I think that's an excellent point. I mean, yeah.
We have some other people who want to speak on behalf of this bill. If I could, I've got a couple other folks that have questions, but just want the committee to know other folks will be testifying, and then we'll entertain that motion. But with that, Senator Douglas, you have a question, comment?
Thank you, Mr. Chair. Representative Mosier, first of all, I want to thank you and your guests this morning for the information that they brought. If you would, or either of them, either of your guests can speak on this, about the possible future expansion of the biomarkers. I know today we've spoken primarily of lung cancer, but could you give us some information on the possible implications of the future? Thank you.
Mm-hmm.
Yeah, we're truly entering a renaissance in the treatment of cancer. You just speak about lung cancer, for example. Just 10 years ago, 50% of the non-small cell lung cancers that were biopsied had a targetable mutation. Today, 90% of the non-small cell lung cancers that are biopsied have a targetable mutation. So we can use precision medicine to target those mutations and get the results that we're seeing here. This is happening with many other types of cancers. Lung cancer has led the charge. There's a lot of lung cancer now that does have a targetable mutation and that has had very good results in a very deadly cancer. But this is also happening in just about every other type of cancer there is. And collectively, we're going to see a big change in the survival of all walks of patients with cancer.
So I could just give a specific example of something that happened in January. In breast cancer, a new drug was approved for ESR mutations, and approximately 50% of patients with breast cancer are going to be a candidate for this drug based on their mutation status. And so it's really, I cannot echo enough the tremendous advances we're making in both understanding cancer and identifying new treatments that are dozens of studies have shown that targeted therapies are both more effective and have less adverse effects than our standard approaches for treating cancer over the decades.
Yeah, 60% of the drugs that have come out for treating cancer in the last 5 years require biomarker testing for their use.
Senator Carroll, you have a question?
Just quickly, Mr. Chairman, in relation to the labs that do this testing, are there numerous labs across the country? And as it stands now, are the insurance companies ever covering this testing? Is it hit and miss, or where are we with that?
So I could comment on that, I think. So there are a number of different testing companies that are across the United States. There are also local laboratories that set up this testing, like a hospital can sometimes set up this testing. Medicare does have a code for it. And so there is a push for this, and it is, I guess I would also emphasize that it is standard of care testing that everybody should have access to.
Mr. Chairman, these technologies or these advances are exciting, and I can say from a personal experience with genetic testing, my daughter has cerebral palsy. We had concerns about her next surgery working or not working because the last one did not work, made her worse. So we went through genetic testing and were able to determine the gene, the defective gene that related to her cerebral palsy. So we know that her surgery is likely going to be of benefit to her. So the pharmaco, I think that's the correct term, all of these things that are happening, you all have seen the report that we are rated as one of the worst, if the worst place to retire in the country. And one of the top 3 reasons has to do with health care. So anything that we can do as a state to improve health care opportunities, all the things that we deal with in this committee, we have a lot of work to do. That's embarrassing to be considered. And I know with Wallet Hub, there are a lot of different organizations that make these ratings, but we're better than that, and we have a lot of work to do. And it's things like this that can advance medicine within the Commonwealth and create for a healthier population. And these things are crucial, that we take advantage of the science that's there to improve the healthcare outcomes in our state. Thank you, Mr. Chairman.
Thank you, Senator Carroll, and I agree with your comments. And I'm a little bit surprised by the fiscal note. It kind of seemed like it was indifferent. I think there'll be a huge savings. We'll realize long term on this, and improve the quality of life and quality of care for everyone that's involved with this. So I think it's exciting as when we did colon cancer screening 20 years ago. It's that revolutionary, and I'm looking forward to seeing what's next. But if you folks would excuse yourself from the table, we have a couple of folks that want to testify about this bill. Mr. Tim Stevens and Mr. Scott Brinkman. Welcome to the committee. You gentlemen have been here before, so you know the routine. If you would identify yourself for the record, and feel free to proceed.
Thank you, Mr. Chairman. My name is Tom Stevens. I'm president of the Kentucky Association of Health Plans. Want to clarify that our members do support the legislation today. We have shared with you some concerns that we also shared with Chairwoman Mosier on the bill. And I think there's really just two areas that we wanted to touch on today. One is on a limitation on the bill to really focus on what the testimony has been about, which is to cancer screening processes. I can say I just clarified again with our membership this morning, and they have in fact paid for tens of thousands of these tests in the last year. Talking to our largest commercial carrier, they provided me with some numbers. It's $107,000 that they paid for last year. So I do agree that this is becoming standard of care. The second issue is specific with a limitation on the consensus statement language that's contained within the bill. And I think my colleague, Mr. Brinkman, is going to discuss that.
Yes, and I'm Scott Brinkman with Connecting the Dots Policy Solutions, representing the Kentucky Association of Health Plans. And I want to reiterate that the Kentucky Association of Health Plans and our member plans totally support the spirit and intent of this legislation. As we share with the members of this committee the excitement with what's developing with biomarker testing. We simply want to point out that that this is a health insurance mandate, and our philosophy is that health insurance mandates should always accomplish its goal in terms of the health condition that's being addressed by the mandate, but also that legislation that creates health insurance mandates should be drafted in a way to preclude the possibility of inappropriate health care spending, because we know that health care costs in this country are very, very high. So to my colleague's point, we know that biomarker testing is very effective in the area of cancer, and we suggest that at this point the legislation be drafted to cover biomarker testing to detect signs of cancer and cancer-related conditions. As the science evolves, certainly, and if there are non-cancer health conditions for which biomarker testing proves to be very effective, this body certainly can expand upon that legislation in future years. But to date, as the proponents have so eloquently testified, their focus is on cancer and cancer-related conditions. The second point is Section 2 of the bill. There's 7 suggested sources of information to provide the medical and scientific evidence supporting medical necessity. We totally support 5 of those 7 proposed sources of information, but 2 of those sources of information, one is the local coverage determinations in the context of Medicare administrative contractors, plus consensus statements. Our experience has been that there's a wide variance of opinion, medical opinion, within those 2 sources of information, and we believe that at this point it would be more appropriate to limit the suggested sources of information to 5 of the 7, but to preclude consensus statements and local coverage determinations, simply because there's such a wide variance of medical opinion within those 2 sources of information. Other than that, we totally support the bill, understand that this is an exciting frontier that will benefit, no doubt, thousands and thousands of Kentuckians. But it is a health insurance mandate, and we just believe that as a philosophical matter, that health insurance mandates should be drafted in a way that accomplishes the the goal of the legislation, but to not open the door to possible inappropriate healthcare spending. Thank you, Mr. Chairman, members of the committee.
Thank you. We do have a question. Senator Berg.
Thank you. I just want to make sure I'm following you when you talk about the 5 of them. I have an A through G, with G being consensus statements. You want that taken out of there?
Yes, we think.
And where's the local one?
It's E, Medicare Administrator Contractor, Local Coverage Determinations. Again, we feel that our experience has been that there's a wide variance of medical opinion within the context of local coverage determinations. So it's those two suggested sources of information.
I would like to actually strongly disagree with you on consensus statements.
Okay.
I mean, when we publish consensus statements, that is the best of the best of the best getting together and trying to update the rest of us on what is current standard and accepted practice. So to take that out basically moves us back 2, 3, 4 years, because beyond those consensus statements, then you have to do the documentation. So I would really want to disagree with you on that. And I just want to bring up, I think it's honestly sad that we're here. I think it's really sad that we have to legislate that insurance companies are actually going to cover exams that dictate how we treat patients. I mean, for me personally, when I was diagnosed with breast cancer, I had excellent insurance. I was in private practice. I paid almost nothing except for this, except for my genomic testing, which actually made the difference on how long I stayed on chemotherapy. The cost of the test was less than the 2 cycles of chemo that I opted out of on the basis of that test. The fact that you all are here being required to do this, I think is a sad statement. Thank you.
Thank you.
Could I also strongly disagree with taking out the consensus statements?
Yes, please.
I support that. I strongly disagree with taking out consensus statements because those are well established in oncology as to be expert opinion based on very intense scrutiny of the literature and coming together. The NCCN guidelines are the most common consensus statements in oncology, and those statements are put together by a national body of comprehensive cancer centers and experts. So,
thank you. Appreciate that opinion. There will be no further questions, comments. Representative Moser, I'll invite you back to the table for final comments before action on the bill.
Thank you, Mr. Chairman.
Thank you, gentlemen. Appreciate you being here this morning.
Well, thank you, Mr. Chairman. I think I'd just like to clarify a few things. We have talked at great length about the consensus statements, and it has been narrowly tailored to nationally recognized clinical standards. And so I think that, we are pretty clear on the consensus statement being a part of this bill. Also, I should just add that I'm very glad that the insurance providers are beginning to cover this testing, but Kentucky still ranks 42nd in the nation for this testing. With our #1 standing as #1 in the nation with lung cancer, I strongly suggest that we move ahead with some of these cutting-edge treatments and testing. To Senator Carroll's point, and Mr. Brinkman brought up, I think he was trying to say that we should narrowly focus this to only biomarker testing, because in the language we include pharmacogenetic testing, which is probably what your daughter had, to identify how she metabolizes certain medications. And this too is up-and-coming testing, which allows us to target treatment and target those medications for folks who may have a psychiatric condition and they need a certain medication. We don't want to put these patients through trial and error of periods of great instability in their life if they can simply get the right drug, the right medication at the right time. And so that's what this does. All of these tests have to be prescribed by a physician. They all have to be medically necessary. We did not actually change the prior authorization in this bill. It's unchanged, so it still has to be approved by the insurance companies. And so we have worked for a long time to get this right, to ensure that there are guardrails and that patients can still get the right testing at the right time. So if you have any further questions, I'm happy to answer any of your questions.
Seeing none, we have a motion from Senator Adams. Is there a second by Senator Berg? Secretary, please call the roll.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg,
And I really, really want to express a huge thank you. This is needed and this is excellent. Thank you.
Senator Carroll,
Aye.
Senator Douglas,
Aye.
Senator Funky Fromeyer, Senator Nemes,
Aye.
Senator Tishner, Senator Wise, Chairman Meredith.
Aye. I would entertain that, Senator Adams, but you may recall that someone wants to speak about this on the floor, again, because it's such exciting technology for us. So we do have a request to...
I would agree with that. I think it's very exciting for Kentucky to be this cutting edge.
Well, the vote is 10-0, obviously passive favorable expression, so congratulations.
Thank you.
Representative Mosier, appreciate you being here today. Our last order of business is we do have some regulations that have been circulated to you. Most of these, if you have reviewed them, you know they're wordsmithing kind of in nature. I didn't see anything of substance, but if there are no questions, comments, we will consider them reviewed. With that, I want to remind you that our next meeting is scheduled for Tuesday, March 15th at 10 a.m.
Wednesday, I'm sorry.
Excuse me, Wednesday. I can't believe that Becky actually made a mistake. First time in the 7 years I've been here. But again, Wednesday, March 15th at 10 o'clock, we'll be in this room. But just want to caution you that as we're ending this session, this is subject to change. And so just be prepared for that. With that, there's no other business. We stand adjourned. Appreciate everyone attending.
Just the top line.